Both kyphoplasty and sacroplasty are performed only if there are certain clinical symptoms for these procedures, i.e., only in cases where the patient suffers from pain and mobility limitations. In addition, in this context, the risk of loss of spinal stability is particularly important. This means that for benign diseases such as osteoporosis, it is possible to try to stabilize the spine with a corset and other methods. However, if the patient still requires painkillers after such treatment, and morphine is often prescribed in such cases, then it makes sense to consider cement augmentation. This is definitely a situation in which such a procedure is required. Of course, osteopenia should also be considered in cases of osteoporosis. This refers to the degree to which bone mineral density decreases in adjacent vertebrae. After all, during extremely aggressive kyphoplasty involving complete cementation of the vertebral body, an imbalance in stability may ultimately lead to fractures in the adjacent spinal segments above and below. This must be avoided. Sacroplasty works similarly. While it aims to eliminate pain by cementing the damaged vertebral body, it also plays an important role in restoring spinal stability. Another important point is the use of cement and stabilization techniques for malignancies. Despite decades of confirmed data, the fact that up to 30% of new fractures occur during the first 6 to 8 weeks of treatment during radiation therapy for bone metastases, because radiation weakens bone tissue, is still ignored. This is due to the work of osteoblasts and osteoclasts. Osteoblasts form bone tissue, while osteoclasts destroy it. In other words, it is much more reasonable to stabilize the affected bone with cement before radiation therapy, in cases of high fracture risk, such as when there are metastases in the vertebral body or sarcoma metastases. This makes it possible to stabilize the affected bone and eliminate the risk of spinal instability. With this tactic, patients typically experience pain relief in a relatively short period of time. They can then stop taking morphine and undergo radiation therapy calmly. It is also much easier for them to lie down, etc. This means that there is no risk of developing recurrent fractures during radiation therapy. I can only call on all to take advantage of this treatment, as it can relieve a lot of suffering, pain, and discomfort that, in the worst case, forces patients to discontinue their treatment. For example, our clinic offers everything under one roof. I perform cementation of the bone affected by metastases, and after 2 to 3 days, when the patient is pain-free, we proceed with radiation therapy. Frankly speaking, the best and most sparing treatment option, which has no alternative, is the combination therapy, which we have already discussed. Ultimately, it is simply impossible to choose the best treatment option for a patient without interdisciplinary boards and cooperation between doctors. Therefore, following the principles of modern medicine, irradiating metastases in the vertebral bodies in the hope that a fracture will not occur is an absolutely inappropriate approach. On the one hand, thanks to new image guidance technologies, we have significantly increased the safety of treatment. On the other hand, we have more and more advanced systems for performing combination treatments. These systems are specifically designed, for example, to perform radiofrequency ablation of the affected vertebral body in one session using one instrument, and then cement the vertebral body using the same instrument. This is a big advantage, because this approach enables us to perform one procedure instead of two. Radiofrequency ablation destroys cancer cells, either partially or completely, and then the vertebral body is cemented to stabilize the spine and relieve pain during the same procedure. This is just one example of combination therapy. Similarly, kyphoplasty can be performed in combination with brachytherapy, which is internal short-range irradiation. According to one of the new publications, and we have already performed such combination therapy in our clinic, kyphoplasty can be combined with electrochemotherapy for tumors that are not only localized in the vertebral bodies, but have also grown into their surrounding muscles and connective tissues. So, we are heading in the right direction. Treatment options are improving every month, not even every year. New discoveries regarding the areas of application of these treatment methods are made every month, and it is extremely important that you, as a specialist, are aware of all these advances. Of course, we are also grateful to our associations, particularly the German, European, and American ones. They have a really well-established system for training and informing doctors about the latest advances.